Okay, well, thank you, Ellison. Thank you so much for having me. I appreciate being able to meet with you all today, and thanks for taking the time to be here. I want to talk a little bit about a topic that we don't talk about a lot, and I haven't seen discussed, but we see it in our clinic a lot, and that is the idea of the brain and its metabolism. And so metabolism is generally thought of as how a cell takes energy from mostly our food and turns it into energy, and how it runs sort of all the cellular processes. So it's basically how the cell kind of keeps itself functioning and does all its different processes. And when I go to lectures or I go to meetings, I often hear about the Alzheimer's primarily from the perspective of these abnormal proteins. So everybody, I think, knows a little bit about those plaques and tangles. But we don't really talk about what's going on from a metabolic standpoint. And there's a lot of evidence that one of the reasons people experience cognitive decline is not just from the proteins themselves, but from a decline in how the body is able to use and utilize energy. And that's important because we think that maybe that's a driving force for why these proteins show up in the first place. And the brain is a very important metabolic organ. For example, of all the body's energy production, 20% comes from the brain, and the brain is only 5% of body weight. So it's a disproportionately important energy source for our body. And so if that goes wrong, we think that that may have a big role in cognitive decline. And so we'll talk about that today. And so I think, as I mentioned before, people have maybe seen these slides. These are the plaques that we can see under a microscope, and you stain the brain tissue, and these plaques kind of turn black, and you can see them very closely. But we've known about these since like 1906, when Dr. Alzheimer first discovered these plaques in a patient that he had, and he said this is very abnormal and unusual. And it turns out that this is what we see in the brain of people with Alzheimer's, and now we can image this. We can do scans that can see these plaques during life. It used to only be we see these at autopsy, but there's been a disproportionate, I think, focus on plaques and tangles because we can see them. But what's driving these plaques and tangles in the first place? We know these plaques damage neurons, but many people accumulate amyloid and they never develop dementia. Lots of people have lived into their hundreds with amyloid plaque in their brain without having any symptoms. And also, proteins themselves don't always correlate to the symptoms a person's having. So the plaque probably doesn't tell the whole story. And so for me, I think we need to go back a little bit further and say maybe the cells are getting sick before the plaques show up. And maybe some of this process can explain some of the symptoms that people experience as they experience dementia, Alzheimer's, and cognitive decline. So we're going to go into a little bit of that. We're not going to go at too deep of a level, but this beginning part is just a sort of an overview of what may be happening cellularly. So one of the problems we see in people who have experienced dementia and cognitive decline is that their neurons are not able to really handle stress very well. And so the neurons actually start looking kind of sick, and they don't produce ATP as well. And so we think one of the reasons why plaque gets formed in the first place, or not cleaned up, is the cells really can't keep up with the demand. And so we see this feed forward loop. So the cells get sick, they can't clear up the plaque is toxic, and it sort of drives the whole process. And so it's really important to think about these parts of cells called the mitochondria. And the only reason to know about this is because some of the new therapies, some of the new treatments may target mitochondrial function. If we can power these cells, maybe we'll be able to repair some of the damage that's being done. the primary function of mitochondria is to produce ATP. ATP is a very important energy source for the brain. So these mitochondria are churning out power for the brain. And so we think that dysfunction of the mitochondrial cells may be a really important clue to why some people get Alzheimer's disease. And now there's a lot of research that says that these mitochondrial cells really start to fail early on before the onset of symptoms. So this is something to pay attention to, this function of these mitochondrial cells. And so we see that up to 10 to 20 years before the onset of dementia symptoms, these mitochondria start to diminish in their ability to produce ATP, and it leads to a variety of symptoms within the cell at the biochemical level, and primarily this thing called oxidative stress, the cell's inability to kind of clean itself up. And so what we're seeing is this pattern of these healthy energy powerhouses within the cells not being able to keep up with the cleaning function. And so these cells start to age a little bit. And we think maybe that's the key to why these proteins build up later in life. And maybe that's what we're seeing. So the proteins may be an end product of a process that starts well beyond their formation. And so I think this holds some keys as we're talking about maybe new therapies or prevention strategies and why it's so important to kind of have a little bit of understanding about that. And so now I'm going to talk a little bit about how this may show up in patients and some unusual phenomenon that we see in people that develop dementia or Alzheimer's disease. One of the interesting phenomenon that we see in people is many years before the onset of their diagnosis, we see a notable decline in weight. And so it's a very, very known fact that maybe 5 to 10 years before a person starts having memory problems, they may start to lose a lot of weight. And it's usually unexplained. It's not from dieting. It's not from changing medicines. It just seems to be a phenomenon of the condition itself. And then that continues after a diagnosis. And so it's very common for us in our clinic to see people have a history where, they've lost 20 pounds in the year before they started having memory loss, or they've lost 40 pounds, or they've lost 60 pounds. And it just seems to happen. And then after they're diagnosed, they may have been heavy before the onset of their symptoms, but they continue to lose weight even though a person eats a lot. And that may be due to the fact that those mitochondrial cells are not able to utilize fuel as well. So this is a phenomenon that I think supports the idea that the cellular metabolism in the body is really changing, and it's changing much earlier than the onset of those plaques and tangles. Another thing we see is that even though people may lose weight right before their diagnosis of dementia or Alzheimer's, a big risk factor for the development of the disease is not losing weight, but it's actually what happens before that, which is people can develop this thing called metabolic syndrome, where they're gaining weight, they're developing diabetes, and they're getting high blood pressure and sleep apnea. That turns out to be one of the major risk factors for dementia, but that risk factor is in midlife. It's in people in their 30s, 40s, and 50s. That's when those are risk factors primarily for dementia. So it's many years before the onset of the weight loss and the symptoms. And so we want people to be as metabolically healthy as young as possible. And so we know that a rising problem across the entire globe is this increase in diabetes and sedentary lifestyle and not being as physically active. And we think that's going to put more people at risk for developing dementia later in life because we're doing something wrong with the metabolism earlier in life than it should be. And so even though weight loss tends to be a closer phenomenon to when decline is, problems with metabolism before that seem to put a person at higher risk. So, and that's reflected in the fact that metabolic function is largely restored when we sleep, that people right before the onset of their diagnosis of dementia or after their diagnosis of dementia tend to sleep longer, have increased daytime sleepiness, maybe have increased naps. And so we see this very commonly in our clinic that patients, after their diagnosis, they really need a lot more sleep. On average, in our clinic, folks need about 12 hours. And I tell families, we need to plan around a 12-hour time period of sleep during a 24-hour period to really function well. And so I think that's a reflection of the fact that the metabolic needs of the cells have changed. So this is a very common phenomenon we see, is the need for longer sleep. And I think that reflects why the fact that the metabolism off is why people need more sleep. And I don't think the amyloid plaques and tau tangles would explain that. But if we're talking about actually the problem is before that, it's with the mitochondrial cells, that makes sense to me. Again, we talked a little bit about the risk factors in midlife that may predispose a person to having dementia later in life. Again, this is about the idea of metabolism. So we want to tell younger generations, particularly people in their 20s, 30s, 40s, and 50s, that they need to do as much as they can to avoid developing diabetes, to watch their weight, to be physically active, and to avoid hypertension. Once we see these things start to tear down that metabolic function, and they may predispose people earlier in life to developing a problem they wouldn't have. So this is a problem that's not so much for people in the ages of 70s and 80s and 90s, but this is more of a problem in younger generations. And that's why it's so important that we encourage younger generations to be very active, watch what they're eating, avoiding sugars, and keeping on top of their weight, not because of what's going to happen with taking insulin or medications, but later in life, it may predispose them to developing dementia. And so one of the key diagnostic clues to a person having dementia or Alzheimer's disease is a thing called a PET scan. And there's different types of PET scans. One type of PET scan looks at amyloid plaque, and that's very helpful for seeing the plaque. But another helpful scan is something called a FDG PET scan. That's a sugar PET scan. And what we're seeing in this picture right here is the change that an individual experiences when they go from normal cognition to mild cognitive impairment to Alzheimer's disease is the reduction in their body's ability to uptake sugar. And so we see bright red is the cells taking up sugar. And as they get to being more yellow and blue, we can see that expansion of that blue area there. The brain is not able to utilize sugar as well. And so this is a very important, very well-established biomarker for dementia. So we can see this in real time, that the cells are not as metabolically healthy. They're not able to take up sugar. And so this kind of further points to the fact that we want to keep our sugar and our metabolism as good as possible for as long as possible, because these diseases may be related to metabolism. And so I think we start thinking about Alzheimer's and dementia in a little bit different light, and we can think about them not only as protein diseases, but also as mitochondrial failure, the failure of those cells to be as energy dependent. And that's why we see insulin resistance and we see less energy able for those cells. And so a goal for people who want to prevent dementia and cognitive decline is to keep your body as metabolically healthy as possible. That's why diet, exercise, sleep is so important. If you want to prevent dementia, you have to work on your mitochondrial function. One of the things that's recently come out as a reflection of this is Alzheimer's as type 3 diabetes. And so there's this thought based on primarily that PET scan that what we're seeing in Alzheimer's is a failure of the brain cells to uptake sugar. And that's what diabetes generally is this idea that sugar is floating around in the bloodstream and the cells can't take it up. And so we don't have enough insulin. The cells are resistant to normal amounts of insulin. And so some research are pursuing this idea that Alzheimer's is really a version of that. And those cells are unhealthy. So, and researchers are actively working on ways to get those mitochondrial cells to function better and more effectively. And so this has kind of come out because it sort of makes sense. It doesn't mean that diabetes necessarily causes Alzheimer's disease. It seems to be a different version of diabetes. So people that have diabetes, not everybody with diabetes goes on to develop Alzheimer's. Certainly some people with Alzheimer's disease, many people with Alzheimer's don't have diabetes. So it's a different phenomenon, but it's similar in the sense of the biochemistry kind of is very reflective. So it's a different process, but similar in the sense that the cells can't take up sugar in the same way. But it's not diabetes causes Alzheimer's, Alzheimer's causes diabetes, but the processes are very closely related. And having dementia or having diabetes early in life is certainly probably one of the top 3 risk factors for developing dementia later in life. So we want to avoid diabetes, but they're not exactly the same thing. So this Alzheimer's as type 3 diabetes is sort of an analogy. And I think it's a helpful one to understand, and it's a good one to kind of think about, because I do think this will help us find much more effective treatments and ways to think about dementia going forward. So one of the things that we see in our clinic is sort of the outcomes of what I think are disruptions in metabolism in our patients. And so some of the symptoms are kind of unexplained. Why are people that have Alzheimer's, or why are people with dementia, why do they tend to be a little bit more sleepy? Why do they lose weight at a faster rate than normal generally? Why do they often become cold intolerant? They be cold all the time. Why does their blood pressure drop? And why is there a shift in many patients? We see this really strong shift toward really sweet foods. And for me, I don't have a good understanding on them unless I think about these symptoms from a metabolic perspective. And when we think about these symptoms from a metabolic perspective, it makes sense. We can also kind of anticipate some of the symptoms that we see in our family members that are suffering from dementia. These are often some of the symptoms that we see, and it's not really explained or not really talked about very much. But I think I see a lot of this in a lot of our patients. And if we think about it from a metabolic perspective, we may have a better understanding and maybe even some different treatments. So the question is, why do people with dementia need more sleep? And we don't exactly know why, but I think if we think about it from that metabolic perspective, we say these cells are under a lot of stress, so they need more time to repair themselves. And so I think about if we think that from that perspective, I would say that I would give most patients that have Alzheimer's disease or dementia, especially as the disease is getting a little bit more advanced, their body needs it to help repair some of that degeneration that's happened. So I think it's very common for people to sleep more, and we need to give them more time, especially consolidated sleep. So I'm not a big fan of the idea of waking people up too early in the morning or having early appointments, although we have them in our clinic at 8:30. But where I used to work at Cleveland Clinic, our first appointment was at 7 o'clock, and that was just way too early, and people were not there at their best at that time because they hadn't been going to bed early enough. And so I don't think we should change sleep patterns very much, but I think we should give most of our patients with cognitive issues at least 10 to 12 hours of time every day to sleep. And often we see sort of agitation and behavioral problems emerge when we can't get that amount of sleep. I often get asked questions about travel and going on trips and things of that nature. And I said, one of the big things is we say that's a big stressor to people who travel because they can't get their normal sleep. They're not in their familiar setting. They don't get that 12 to 14 hours, and then the travel schedule doesn't permit that. So for me, I think it's important if we think about what we want to do in terms of travel and going to different locations, that we think about sleep from that perspective. And oftentimes my experience is something where you can guarantee this amount of sleep, like a cruise or something, that's a little bit more tolerated. Traveling to a family member's house where you can kind of control that environment, that travel tends to go better than sort of like a European trip or a tour where you're having to get up at 5 o'clock one morning, 6 o'clock one morning, and that really throws people off because they really do need this time to sleep. We don't want to cause that sleep disruption to impair the sort of normal diurnal day. So we want people sleeping 18 hours or 20 hours because then it just kind of throws off their sleep wake cycle. But we definitely want to allow time for about 10 to 12 hours of sleep every night. So that's an important factor, I think, in where we're thinking about travel and stress, is we need to maintain that sort of normal sleep wake cycle. So why does weight loss occur? We talked a lot about before about what happens with people after they've been diagnosed with dementia. They may lose weight and they may continue losing weight even though their diet kind of seems about the same. And here's what we see is that weight loss is incredibly common. People who lose more weight tend to do more poorly because they're more frail. They may be higher risk for fracturing a bone if they fall. So we pay kind of close attention to weight. And what's very commonly occurring is this ATP production doesn't maintain itself. We see a lot of muscle breakdown. And so I think the primary weight loss that occurs in people with dementia is that their muscles are breaking up because they don't have that energy source. So this is about getting enough protein in. And people generally do better when we maintain their weight. So we watch very closely, and you can adjust your diet around this. So another question is, I often get is, why do patients feel cold after they've been diagnosed? They may have blankets on, they may have the thermostat up in the house. When I was in Las Vegas for many years, it's 120 degrees outside and people have the heat on. That's not an unfamiliar occurrence. It sounds awful to me to live like that, but we found that was happening a lot to our patients. And I think it's again related to that ATP production. The cells themselves are not working as well. And so if you think about it from the ATP perspective, it's very common for a person to feel that, especially if they're losing weight. So I think that helps us understand that a little bit better. Blood pressure commonly drops. So one of the features we see in our clinic is people have low blood pressures, a certain subset of patients, especially if they're losing weight. And that's primarily because the muscles are not supporting the blood vessels as well. So this is an argument for continuing to do exercise, even if it's just walking or doing physical therapy regularly, because our blood pressure is often maintained by our muscle tone and how much fluid we have in. And so it's very common for people who are losing weight or not drinking enough water. When they're sitting, they stand up and they get really lightheaded. And blood pressure drop occurs in people after they've been diagnosed with dementia very commonly. And so it's important to know that. It's important for the cardiologist to know that, because we can start peeling off some of those blood pressure medicines that may have a negative impact. Low blood pressure is a much more important impact, has a bigger impact on people with dementia than high blood pressure. So in general, we want to permit a little bit higher blood pressure if it's to avoid a low blood pressure. And so low blood pressure is something that we see commonly and has a big negative impact. If a person has Lewy body disease or Parkinson's disease, the Lewy bodies themselves may get into the heart muscle. The Lewy bodies are actually in the blood vessels themselves and the GI tract. And so everybody with Parkinson's or Lewy body disease has low blood pressure. So if you have one of those conditions, or your family member that you're caring for has one of those conditions, it's really important to be careful about what blood pressure medicines they are, because it's very common to drop. So I guess this is another thing that we see very commonly in our practice, is that people that normally were healthy eaters all of a sudden develop really big cravings for sweets. even to the point where they won't eat their normal dinner. And I guess the question is, why is that happening? And it makes sense from this metabolic perspective. If your body is not producing enough energy, it seems like it's in an energy deficit. And when we're hungry, what do we crave? We don't crave a steak. We crave the potato chips, or we crave whatever we can get our hands on. Or if we're stressed out, there's always a preference for quick glucose. So I think the reward circuitry in the brain is changing in ways to support those cravings rather than that it's a cognitive issue. And I think a lot of patients that are having cognitive issues will just intuitively go for the sweets because it feels good, tastes good, but mostly because their brain is craving those sweets. And so that's good to know. In general, we say, well, just take the sweets out of the house or limit the exposure to them because otherwise they're going to be eaten. And so we commonly see this. And if you kind of understand where that's coming from, I think that's helpful. So what are our goals for achieving a sort of metabolic support? If we're just thinking about plaques and proteins, we have a lot of folks that may be on these IV therapies that are clearing the plaques and proteins. But that doesn't seem to be sufficient enough to really cure the problem. It does help a lot, but what else can we do to support this metabolic dysfunction that's going on? One, we want to stabilize our blood sugar. We don't want people going up and down. We want to support cellular energy. So we want to increase the amount of healthy energy that the brain and body can utilize. So we want to preserve our muscle mass. So these are really important. These are really important goals to shoot for. So one of the things we always try to avoid is calorie restriction. A lot of folks that develop Alzheimer's or dementia when they live alone have this weight loss problem, and then they don't eat because it's too hard or it's challenging. So a lot of family members are really struggling to get mom, who's staying at home all day, to eat, or dad to eat enough. And so we certainly want to avoid calorie restriction. People are on diets to maintain a certain appearance, and those are very poor. Those will tend to make their symptoms worse. So we want to make sure that a person's getting in at least 1 gram of protein per kilogram per day. So that's a lot. So we often have to supplement that with high protein sources and high healthy fat sources like avocados, protein bars. When we're eating, we want to focus on eating the protein sources first. If somebody's sort of appetite is reduced, we want to really maintain that protein level in. We want to improve muscle strength. So it's really important to consider doing physical therapy, physical activity every day, particularly activity that includes some weight training, because for whatever reason, building muscle supports that ATP process. And so I think it's important to consider some form of regular exercise, whatever that is. If it's chair exercise, if it's walking, it's going to the gym, it's important to incorporate that as a daily routine. As people develop kind of worsening of their cognition, they'll have less of a motivation to do that. So often they need a partner to actually go with them, to go to the gym. They won't do it on their own, but it's really an important part of a treatment plan. So if you have access to a friend or a family member that likes walking, encourage them to maybe help out with a person that's experiencing some cognitive decline, because we really do want to keep the body moving. And this seems to be a treatment. And this is why I think that there have been numbers of studies that have shown that people who stay physically active do better cognitively. There are some supplements and ways to power the mitochondria. Red light therapy turns out to be a therapy that can maybe activate some of the mitochondrial cells. And so that's something that's potentially in development. I know there's a lot of companies that try to sell you products that are less established, and I'm not advocating for use of that, but hopefully we're going to see more clinical trials in that area where we're working on things that can support the mitochondria. One of the ones that has some theoretical support, experimental support, it hasn't been proven true, is this NAD+, which can be converted to ATP by the cells themselves. So could potentially think about this as something that could help support the function of the cells themselves. Again, this is experimental. It's been studied primarily in mice and rats, and we know how that research goes, that it's very promising in the early stages and it kind of peters out. But there was a recent study from Case Western in Cleveland that showed that mice that they kind of gave Alzheimer's disease by the way you can introduce genes into the brains of mice, had really low levels of NAD, and their cells were not producing, because of this, cells were not producing ATP. So one of the potential solutions for that is an NAD supplement, and we have enough people that have been on this to say it's not a cure, certainly, but it could be something that may be helpful. So we'll keep our ears open for potential clinical trials in this area, but this seems like a promising line of research. What else can you do to support your energy function of the brain? Like we talked about before, allowing extended hours of sleep. We may think that a person may need 10 to 12 hours, and it seems like that's often appropriate to do that repair. We're all kind of wired for a specific sleep pattern, and that takes a little bit of time to unwire. But in general, this range is not perfect for everybody. This is kind of the average range, but some people may need 8 hours of sleep. Some people may need 13 to 14 hours of sleep, but in general, the average is 10 to 12 hours of sleep. People without cognitive issues, without this metabolic problem, generally need 7 hours of sleep at a minimum. So if you're thinking about prevention, if you're in sort of that prevention area, we say we want to get a good night's sleep, and we want to prioritize sleep, because that's when this mitochondrial function can repair itself. That's when this ATP production is going. So if you're a person that's really interested in prevention and you're not getting good enough sleep, you're not doing all the things that you can do to help your brain. One of the things that comes up a lot is, what should we do for patients with diabetes that have a diagnosis of Alzheimer's disease or dementia? The shift kind of comes after that diagnosis. So prior to the diagnosis, we want to be very, very good with our glycemic control. But after we have a diagnosis of diabetes, we want to start, of Alzheimer's disease or dementia. We want to shift our goal away from tight control to avoiding hypoglycemia. One, because hypoglycemia causes things like fainting, it causes things like lightheaded. People hypoglycemic start shaking, they may have problems with their mood, and it's very dangerous to the brain to have low sugar, and so that's a medical emergency. So we want to do everything we can to avoid hypoglycemia. If you think about hypoglycemia from the context of dementia being a disease of energy, there's nothing worse for the energy to the brain than to have low amounts of sugar. So we want to avoid this at all costs. So up to the point where the diagnosis occurs of dementia, we want to be very tight with our sugar control. But after that diagnosis, we can permit to be a little bit higher on our sugar, because we don't want to run out of sugar. The A1C goals for people with dementia vary on the severity. So if we're mild stage of Alzheimer's disease, we're mostly able to do things on our own, but may need kind of daily reminders and hints to get things done. Our goal is 7 to 7.5. This is from the American this is American Diabetic Association. So these are not my guidelines; these are published guidelines. If you're moderate stage dementia, so that means you need help with hygiene and help with reminders for hygiene, or need hands-on for hygiene, our goal is a little bit higher, so 7.5 to 8. And if we're in the moderate, and so if we progress from the moderate to severe stages of dementia, where we need help with our daily activities, our goal for A1C is closer to 8. We allow people to be a little bit higher in general. So this is just general guidelines. If folks have problems with wound healing and other issues related to their diabetes, the control may be tighter, but these are the general recommended A1C targets, primarily to avoid that hypoglycemia. Before the diagnosis of Alzheimer's dementia, our goals are much lower into the sixes, the mid sixes. But once we have that diagnosis, we want to avoid that. There's two medicines or two medication regimens that tend to lend themselves to hypoglycemia. One is glyburide, and the other is sliding scale insulin. These tend to drop our blood sugars. And so in general, if we can get away from these types of medicines and simplify our routine, that's a better strategy. One of the things that we also want to avoid is weight loss and dehydration. And one of the most common side effects to our medicine specifically for Alzheimer's disease, like donepezil and galantamine and rivastigmine, it predisposes people to diarrhea, because when you have too much acetylcholine in the GI system, it tends to cause cramping. And so we don't absorb our food, and we may have these explosive episodes of diarrhea. And so we want to avoid this. So it's very common when a doctor either starts or increases the dose of the medicines that do help the brain function a little bit better, that we can run into this problem. And so we want to be very careful that we don't let diarrhea go, that we see this as a serious, especially chronic diarrhea, as a serious symptom, because it means that we're not really absorbing our nutrients, and this may lead to weight loss. So I think of diarrhea in people with cognitive issues and dementia to be very, very careful. When we combine donepezil with metformin, or if we combined donepezil with some of the new anti-diabetic medicines like Ozempic and Wegovy, we may have a higher risk for developing dementia. So these combinations we kind of need to pay attention to. Strategies to reduce diarrhea include like slow titration with the medicines, take with food, maybe not being on such a high dose. But diarrhea is a serious symptom. We want to hear about that from our patients that have that. And oftentimes we'll have to take them off their dementia medicine because it's going to counteract the benefits we get from that. So we want to make sure that this metabolism is important to treatment. So if we say you have to take you off the medicine, that's okay. We want to really re-support that metabolic function. That's important. So I think a metabolic model of dementia goes beyond the proteins themselves, and it goes to the point of these mitochondrial cells that power what the brain is doing. So we start thinking about this more than just plaques and tangles. We think about this as an energy failure in the disease, and that helps me kind of understand and look at patients. And I think this will lead to more and more different types of research, and it helps us kind of understand the disease itself and ways to prevent or lessen the impact of the disease. What we should kind of monitor as caregivers and as providers of patients with cognitive issues and dementia is I think, pay attention to weight and monitor that. And sometimes we just can't do anything about weight. The weight is just coming off, and we're eating, we're trying as best as we can. But we should at least try strategies that can address weight, and whether that's meal replacements, whether that's maybe shifting the diet a little bit. I think that's important. Sleep's important, and we want to make sure, especially when we're traveling or not in our normal environment or having to be in the hospital, that we're giving back that sleep. We want to work on muscle strength, so muscle building activities like walking and exercise. And if we can get light weights, I think that's helpful because that builds the ATP function of the cells. And we want to watch blood sugar, particularly having too low blood sugar after the disease is developed, because that's a very important resource. So I think that metabolism is an important part of driving dementia. I think after the diagnosis of dementia, it becomes an even more important part of the symptoms. And I think many of the symptoms reflect a failure of energy, not so much at the holistic level of energy, but failure at the individual cell levels. And that will lead to a different understanding. We're moving to a place in where the science is going, that we're thinking more about how we can power these mitochondrial cells. We have examples of that with the red light therapy potentially, and NAD plus and other supplements that may power mitochondria. They're still experimental. We don't know exactly how this works in humans, but we're seeing evidence from mice that building these mitochondrial may be really effective therapies that can't be recommended at this time until we know more, but they may be a benefit for patients. And so I think of dementia and the dementias in general as somewhat of a disorder of brain energy. And so supporting that is one of the treatments that we've kind of neglected in terms of when we're addressing dementia in general. We don't talk a lot about energy, and we don't talk a lot how to build up those energy resources, but I think it's really, really important. So the final message is we want to focus on protein-rich foods, prioritize and understand sleep needs, watch for dehydration and diarrhea and low water intake, and we can lower our restriction on our diabetes control. We can be a little bit permissive. So that's kind of some of the things we've been thinking about more recently when it comes to metabolism, and maybe a different take on the typical proteins and tangles when it comes to dementia. So that's all I have today. So I think we have at least a couple minutes for